I'm delighted now to welcome our next speaker, Dr. Melody Howe, who will be presenting on difficult IUD insertions and removals. Dr. Howe is the Director of Medical Student Education and an Associate Professor of Clinical OBGYN in the Division of Family Planning at the University of California, Davis School of Medicine. She graduated from Harvard Medical School, completed residency at Beth Israel Deaconess Medical Center, and trained as a fellow in complex family planning at Brigham and Women's Hospital and Planned Parenthood League of Massachusetts. She served as faculty at Boston Medical Center before moving to UC Davis in 2012. Welcome, Dr. Howe.
Thank you very much for that introduction. So one of the things that I was thinking about as we are going now into the 3.5-hour mark of this conference is how my talk, although it feels very medically oriented, it does lend itself to the idea of if someone wants an IUD, how can we best facilitate getting them? And if someone does not want the IUD, how can we best facilitate getting it out of them when they want it out? And so I think with that perspective, it has made it helpful for me to think about, okay, how does my talk fit into that? Let me get rid of that. Okay, so my disclosures, I am a trainer for Cooper Surgical and I receive research funding from Medicines 360 and Savella, all three of which make IUDs. So the learning objectives of this talk, I'm hoping at the end of this that you'll feel that you can identify interventions for difficult IUD insertions that are due to anatomic distortions or pain, to discuss how do you approach IUD insertion for those interested transmasculine or gender nonconforming individuals, and then how to go about solving an IUD removal complication, such as non-visualized IUD strings, an IUD string that breaks off when you put traction on it, or even a fractured IUD. So when you do have someone where you might have a difficult IUD insertion, you do want to consider whether or not referral is appropriate. I'm hoping with some of the tips and tricks I'm going to share with you here, you won't necessarily need to do that. And so again, I'll be focusing on these three particular topics. One way to think about is just to figure out what kind of tools we're dealing with. And so these are the 5 IUDs that are currently on the market here in the United States and the size of their IUD inserters. They range from almost 5 millimeters for the Aletta IUD at 4.8 millimeters down to 3.65 millimeters for the non-hormonal or copper Paragard IUD. And I ask you to keep this in mind as we talk about how do we get these IUDs placed. So what about anatomic distortions? Risk factors for anatomic distortions include things like nulliparity, or never having had delivered before, having had a cervical excision procedure, for example, a LEAP procedure or a cold knife cone because of cervical dysplasia. Someone may be status quo cesarean delivery. They may have severe flexion of the uterus that has some difficulties with navigation up to the fundus of the uterus, or leiomyoma, also known as fibroids. Now, keep in mind that placing an IUD in someone who has severe anatomic abnormalities is considered category 4 or contraindicated by the CDC in the medical eligibility criteria, but you can do this safely, and I'm hoping some of these tips will help. One thing is to make sure you have a short speculum. If you do, you'll be able to bring the cervix down towards you and straighten out the uterus so that you might be able to access better. And then you can dilate or find a path using an Os finder, which is the blue object here, a tapered uterine sound, or mechanical dilators. Sometimes the curve of the dilators can help you identify the path that you'll need to take, and the IUD inserters themselves will often have a curve, and you can use that to mimic the same path that you've just taken. And finally, ultrasound guidance can be enormously helpful, and I'll show you why in a little bit. So these are some pictures of some more tortuous paths to the uterine fundus, which is where an IUD should be placed. The picture on the left you can see is actually somebody who originally had an anteverted uterus, but some distortion has happened because of a previous cesarean delivery. And you can see here the path where this line, which is the line of the cervix, then naturally curves up for this anteverted or forward bending uterus. But then because of the scarring from the cesarean delivery, you can see that the uterus has been pulled anteriorly, which causes the rest of the uterus to therefore dive back, leading to a retroflex uterus. And you can see now then we don't really have a straight shot at this. And so this is where an ultrasound and using the curve of your dilators and the curve of the inserter can help you navigate around these corners. Also, some mucosal leiomyoma or fibroids can also interfere with that straight shot to the fundus. And so using the ultrasound, again, you can guide your inserter through and then around this fibroid in order to get back to the fundus. So with a combination of these tools, you usually can place an IUD without necessarily having to refer your patient. Now, pain is also a really important factor, and sometimes that can be difficult to overcome. But we do have actually quite a bit of data showing that paracervical block can help with IUD placement at multiple time points, whether it be placing certain number of parts of the instruments or certain steps of the procedure. Just so you have an idea, there's actually multiple ways of administering a cervical block. And I'm just showing the anatomy of the cervix and the uterus here so you can see where these may be placed. Most of the data that have been published has been mostly on the paracervical block, but this is not to say that any of these other options are not necessarily helpful. But of what the data has been published, this is looking at the cervix straight on. You can see the vaginal walls I've made with these little objects here. If you administer about 10 to 20 milliliters of 1% lidocaine, give a little bit at the tenaculum site block, and then the rest at the cervical vaginal junctions at 4 and 8 o'clock, aiming for the uterosacral ligaments at varying depths, you usually can overcome patient pain at the time of insertion. And there was a study that was actually done by Dr. Trock's group a few years ago that showed that an intervention demonstrating to advanced practice clinicians on how to use cervical dilation and a paracervical block allowed them to actually place more IUDs at the time that the patient has requested it, rather than having to refer to another time. Now, there has been a lot of use of misoprostol over the years, and unfortunately that practice still persists. And I say that unfortunately because there's actually quite a large body of evidence at this point that shows that routine misoprostol with the idea of cervical softening to allow for easier placement of the IUD does not work. It does not improve pain, and in fact actually does increase uterine cramping and increase side effects such as nausea, vomiting, and diarrhea. And so routine misoprostol use with anticipation of a difficult IUD insertion, I would not recommend. Now, for transmasculine gender nonconforming individuals, IUDs may be helpful. They may be helpful for menstrual suppression, and it may be helpful for pregnancy prevention if their sexuality puts them at risk in terms of what partners that they have. Now, some of you may say, well, testosterone has been known to suppress fertility. Isn't that going to be enough? You're right. Testosterone does decrease fertility. It does help suppress menstrual bleeding, but we're never going to get an actual Pearl index proving its efficacy as a contraceptive. And so real world effectiveness is not known. And for some individuals, they may like the security of having something like an IUD to prevent pregnancy, or something like an IUD to help with menstrual suppression. And so if someone wants an IUD, talk through the steps of the procedure with them. Tell them what will happen with the pelvic exam. Give them an idea of what to expect afterwards in terms of side effects after the procedure. If you talk to the patient, if it turns out that they would love the idea of an IUD, but they're concerned about undergoing a pelvic exam because that might exacerbate feelings of dysphoria, you might want to consider oral anxiolytic, or even consider more advanced sedation, such as moderate sedation, in order to help them meet that need. And then afterwards, because a lot of patients with an IUD can often have irregular bleeding or cramping, talk to them about those possibilities, because again, it may exacerbate any feelings of dysphoria. Now, you'll read in the literature that sometimes patients with testosterone therapy may have vaginal atrophy, even though testosterone does get aromatase into estrogen. You'll read in the literature that some providers have recommended using vaginal estrogen for these particular patients. But when you look at the data, it actually is not within this population. It's been extrapolated from the data from genitourinary syndrome of menopause, which is not the same population. The menopausal cis woman is not the same as a transmasculine individual. And so if you're going to think about using topical estrogen in this manner, make sure you talk to the patient that, one, there really is no data supporting its use in that population, and that that individual may have specific concerns about the use of estrogen cream for getting an IUD. So hopefully with these tips, you'll be able to place an IUD with that patient when they want it. But sometimes also you can have difficult removals. And for a lot of patients, when they want their IUD out, they want their IUD out right then and there. And so it's important to make sure that you're not forcing that patient to have to suffer keeping that IUD longer than that person wants. And so how do we talk about removal difficulties and approach them? So the most common one tends to be non-visualized strings. Almost 1 in 5 patients will have missing strings at some point during that process of having their IUD. Most of the time, it's just the IUD strings that have retracted within the cervix and uterus, and you can cope with that in the office pretty easily. If it's within the cervix, many times you can use a cider brush, which is one part of the PACCK test that we do frequently in the office. What you'll do is that you'll insert the cider brush into the cervix, you twirl it, and oftentimes the strings will get caught up within the bristles, so that when you remove that cider brush, the strings will then emerge, and then you can grasp the strings and remove the IUD. If it has withdrawn into the uterus itself, there's actually these really neat devices called thread retrievers. They're very thin, very narrow, very comfortable for patients to use for an IUD removal. And the idea is the same concept. You insert this thread retriever into the uterine cavity, you twirl it. It often will tingle the IUD strings within the little notches that you can see in the device. And then when you remove the thread retriever, the IUD strings will usually come with it, and then you can remove the IUD. Now, if you do those two things and the IUD still does not come out, then there's a few things you need to do. One, make sure she's not pregnant. Use emergency contraception if you need to, and then go find that IUD. If you have an ultrasound in the office, then that's great. You can use your ultrasound to look for that IUD. This is what the IUD would look like on ultrasound. The top picture is that of the copper IUD in the uterus, and the metal on the IUD will usually make it very echogenic, this bright white line, and it's very easy to see. A hormonal IUD is a little bit harder to see, but with the right maneuvering, you can usually get that trilaminar look, this sort of triple layer look, which happens because of the hormonal reservoir wrapped around the IUD axis. And this is what a hormonal IUD will look like. Some of the IUDs available on the market will also have a silver ring at the top of the axis that will help also visualize it. Now, if you use your ultrasound and you don't see either of those things, you might have to consider whether or not the IUD has either expelled out of the body or it's somewhere else in the abdomen. And this is where you would get an abdominal x-ray. You want to make sure that the x-ray has covered the costal margins, which is right here, the lower half of the rib cage, all the way down to the pubic symphysis. Now, I do want to reassure you, most of the time, missing strings are not because it's migrated out of the uterus. That accounts for less than 5% of cases. However, if you do get your abdominal x-ray, look out for a IUD shape such as this. This one, in this particular patient, her copper IUD is floating up next to her stomach. And as for the other way that an IUD can look, which is down here around the uterus, this particular patient also has an intrauterine IUD. And this is your Nova T shape. You can see it's a little bit curved at the top here. And this is the most frequent shape for a hormonal IUD. So look for those things if you can't find your IUD in the uterus. Generally, by the way, you don't want to make sure that a patient doesn't get 2 IUDs at the same time. Now, if you know that the IUD is in the uterus, you can keep going in the office. And what you want to use is something called an alligator forceps, which is my favorite instrument in the office. It looks like this, has these little tiny jaws here. You'll see that some people will use other kinds of forceps, such as a Bozeman packing forceps, which is a forceps on the left, and a mitral polyp forceps, which is in the middle, and the IUD hook, which is on the right. I don't generally recommend these instruments, mainly because you'll notice that the fulcrum or the hinge of these forceps is quite far from the tips, versus an alligator forceps where the hinge is quite close to the tip. Now this matters because if you're inserting this instrument into the uterus, you can see that for the alligator forceps, once you have inserted the instrument, you can open those jaws fairly wide and you have a lot of maneuverability. Having the hinge outside the cervix means that you're going to limit how wide you can open any of these other forceps in order to grasp the IUD. As for the IUD hook, these really are designed for more enclosed IUDs or circular IUDs that you'll find in certain overseas countries. And oftentimes with the hook, if you try to use the hook on RT-shaped IUDs, oftentimes it will slide off the arm because of that flexibility, and there's no way to enclose or capture the IUD hook on the IUD. Now, sometimes as you're pulling on the strings break. So one thing you can do is use your ultrasound. Is the IUD malpositioned? This is one picture where you can see on removal, this IUD was not able to navigate coming out through the cervix. And you can see here, I've drawn a line as to what the anatomical canal should be. And so in this situation, you can use, again, my favorite instrument, the alligator forceps, to actually back up the IUD and then guide it out of the cervical canal. If that is unsuccessful, you may have to consider next steps, either in the office while you're still there or in the operating room, either with aspiration, because sometimes the dilation and admittance of the cannula for an aspiration can allow the IUD to navigate that curve, or maybe end up going for a hysteroscopy, either in the office or in the OR, again, depending on what you have available in your office. Now, sometimes as you're pulling on the IUD breaks, which is frightening when you first see that happen. So there's 4 steps I want you to keep in mind. You need to inspect, you want to locate, ask, and then fetch. So what does that mean? Well, inspect what you have really carefully. Know that some things are normal to see. For example, a copper IUD, which is lovely and shiny the first time you take it out of the package, is going to look quite a bit different towards the end of its lifespan. You can see here at 7 years, this particular IUD, some of the copper has already metabolized, and so it'll look as if it might have fractured, but some of this may be actually a natural process. Further, there are some copper IUDs that don't look the same. This is a copper IUD that's available in Europe. You can see it's on a different frame. This is called a Nova T frame, and it doesn't have the copper arms. So again, being aware of what kind of IUD you're dealing with and what you should be expecting when it comes out is going to be very helpful for you. Now, sometimes we had this case we published a few years ago, where when you pull out the IUD, you have no idea what exactly you're looking at. And what has happened here, and what we found out, is that hormonal IUDs, the hormonal reservoir that's usually on the IUD axis, is not actually adherent to the axis. And so when removing it, sometimes a stenotic cervix can hold onto that hormonal reservoir and slide it over the arms or even off the arms as you're removing the IUD. And so you can see here the reservoir that we pulled off the arms, off this Nova T shape. So again, being aware as to what to expect for your IUDs will be really helpful. However, sometimes it really did break. And then that's the case, make sure you take a picture for documentation, and if necessary, refer. Now, you've gotten your documentation, you've inspected it, you've gotten your documentation. Now you're going to have to figure out where that missing piece is. Most of the time, ultrasound will help you with this. This is a case that we had where an arm had broken off the IUD, and we found it that was embedded in the anterior wall of the uterus near the fundus. And in this case, then you'll need to ask the patient what their goals might be. Is it for symptom relief? Is it for pregnancy desires? Because depending on the location of this fragment, it may not interfere with those goals, or those goals may require that you have to go find it. And then that will depend on balancing the benefits and risks of what it would take in order to fetch this segment. Okay. There's also a possibility, there have been case reports of these fragments passing spontaneously on its own with a few cycles, because usually with the menstrual cycle, the uterus will contract. And with that contraction, it may allow for the piece of IUD to go out the way that it came in, because it's a path of least resistance. Now, if it's consistent with the goals based on imaging, you're going to probably need to go fetch it. And there's different ways of doing it. Most of these are all with ultrasound guidance, but you can use alligator forceps in the office, you can use suction in the office, or you might need hysteroscopy. If you do hysteroscopy, I would suggest a progestin course in order to thin out the endometrium to make it easier to see any part of the IUD that may be visible at that point, and have really good graspers. This is a picture from a hysteroscopy where you can see a view of the IUD within the uterus, and this is the grasper that they'll use to then remove it. Sometimes, depending on how embedded that piece is, you may need scissors or a resection instrument. This is a case that we had last year where it was truly embedded in the uterus. We entered with a hysteroscope, we couldn't find any sign of it. Using ultrasound, we were able to resect the endometrium over where we thought the IUD was, and we were able to see it emerge. So we steadily resected it until we had enough room to grasp the IUD and remove it. This is complicated. And so it's important that as you talk to a patient about removing a fragment, that sometimes these efforts may be unsuccessful. So as a recap for difficult IUD insertions, discussion, anesthesia, dilators, and ultrasound. It's really just 4 things in each part that I've been talking about today. So the vast majority of difficult IUD insertions can be accomplished with expectation setting, paracervical block, cervical dilation, and ultrasound guidance. There was a study, as I mentioned, with Dr. Turok's group, where training with advanced practice clinicians show that the use of paracervical block and cervical dilation by themselves can help place what would be otherwise considered difficult IUD insertions. And of course, know when to refer. Similarly, for difficult IUD removals, 4 things: cytobrush or thread retriever, anesthesia, alligator forceps, and ultrasound. Again, the vast majority of missing IUD strings can be fetched with just a cytobrush and thread retriever. Make sure the IUD is in the uterus if you're unable to get any strings with that. And most difficult IUD IUDs can be removed with appropriate expectation setting, paracervical block, alligator forceps, and ultrasound guidance. And similarly to insertions, know when to refer. I think at this point,
thank you.
Questions? Yeah.
We are having questions come in. That was a really helpful discussion, and I think lots of people will be able to go use that in clinic on Monday. Our first question is, my review of the literature involves studies using 400 micrograms as cytotech. I have used 200 micrograms with good results and rare side effects. Are you aware of studies using lower dose?
That's actually, I'm really glad that you've had really good results with that dose. I am not aware of any studies using 200, but I would have to take a look at that. But you're right, the vast majority have been looking at 400 micrograms. That's the typical dose for cervical ripening in other situations. But I'll have to take a look to see what may be available for 200.
We have another question. Would you give meso for a leftover fragment, perhaps with the menstrual cycle?
That's an excellent idea. I have not considered doing so. The case reports, not studies, but case reports that have reported IUD fragment passing has been completely spontaneously, assuming that it is with the menstrual cycle. But that is a fascinating idea.
We've had 3 people write in that your talk is insightful and great and the best they've heard on this topic. So
thank you.
I have another question. I would like to start using paracervical blocks. Any more detail on depth at 4, 8 o'clock? I wonder whether you use 3-inch needles, 1.5 needle extender. Please also confirm with epinephrine.
Those are all great questions. So what's been really fascinating about cervical anesthesia for all sorts of gynecological procedures, whether it be abortions, first trimester, second trimester, dilators, IUD insertions, biopsies, there's really not a lot of consistency as to method, depth, dose, and placement. I can tell you my own anecdotal, which is actually inherited from my fellowship director, Dr. Goldberg, who I saw at this conference, which is that I usually insert about 1 to 2 milliliters of 1% lidocaine, no epinephrine at the tenaculum site. And then I split the remaining 18 milliliters at the 4 and 8 o'clock positions of the cervical vaginal junction. I usually go pretty deep for this. I use the 1.5. Now I'm actually blanking if I do use a 1.5. I believe I use a 1.5 and I go pretty deep with the injection. There was a recent study actually by Dr. White Dr. O'Connell that was recently published looking at dilator insertion and using a lower dose of lidocaine at 12 milliliters, also without epi. And that seemed to be non-inferior to using a 20 milliliter dose. And so our institution is actually making a decision as to whether or not to decrease the amount of lidocaine we're using, because there is some side effects with lidocaine injection with a larger volume. And so that does also need to be balanced against the benefit. And I can see now the chat that some people are using spinal needles as well. Again, you would have to think about the cost benefit ratio. Spinal needles are more expensive. And so depending on what your clinic resources are, you may have to make some decisions.
Thank you so much. Obviously, this is getting a lot of people thinking. I just want to make sure that no one is typing a question before I hand back to Liz. More comments on spinal needles. Okay, well, thank you so much, Melody. This was a really wonderful presentation, very clear. We do have a question about if using a spinal needle, do you go up to 3 inches or stop short? I don't know if anyone is perhaps able to answer in the chat who is using one.
I think the chat is showing why there is such a wide range of practices that's published in the literature. I would say in general, it works however you give it. That's my conclusion of all of the disparities I've been seeing in the literature about how to use it.
Well, thank you so much.